evening to all of you. I will show the important cases from the adrenal pathology, which is important for the examinee. And apart from the spotters, examinee should know, first of all, before going to any examination, they should know about the normal anatomy, vascular supplies, and the role of imaging modalities, because these are the important aspects where the frequently questions are asked in the examinations. And apart from that, also know the different types of the pathologies with different spectrums and the different shapes and the different appearance of the same lesions. Because if only one lesion should be, if anyone knows about the only one type of the lesion, then must be confused with the different appearance of the same kind of the lesion. So must be aware of the different presentation of these different lesions. That is the important. And apart from these lesions, they should also know about how to do the interventional procedures if required for the making the appropriate diagnosis, and also know about the adrenal related the important interventional procedures. So first of all, I will start from the spotters and the first without any history. Spotters doesn't include the any history. Okay. And this is the first case of our spotters, and this is the ultrasound image, and this is the non-contrast images. And in the ultrasound images, it will show there is a well-defined hypoechoic lesion in the suprarenal location, just below the segment 6 of the liver. And this is the non-contrast CT images, and it is showing there is a well-defined hypodense lesion seen in the suprarenal location abutting the liver, and its HU is less than 10 house print unit. So the diagnosis is obvious. It is the adrenal adenoma. Okay, and the next case is the next case is, this is the non-contrast CT scan. This is the portal venous contrast CT scan, and this is the delayed phase of the contrast CT scan. And on the non-contrast CT images, there is a hypodense lesion seen in the suprarenal location, which is measuring the HU of 8, and in the portal venous phase, it is showing the mild contrast enhancement, which is the HU of the 68, and in the delayed phase images, the HU measurement is around 23 HU. So for making the diagnosis of any adenoma, metastasis, or any adrenal lesion, we should know about the absolute percentage washout and the relative percentage washout, and how to calculate these two. It is very important for making the diagnosis of the adrenal pathology. So in this case, the apparent absolute percentage washout is the 75%, and the relative percentage washout is the 66%. So it is a case of the adrenal adenoma again. And the adrenal adenoma is the few salient features about the adrenal adenoma is the most common adrenal tumor. No malignant evolution is seen, and arises from the cortex and consisting of the clear cells with abundant intracytoplasmic fat. This is the important, with the intracytoplasmic fat, and it is incidentally discovered, and incidence increases with the growing age, and majority of them are non-functioning, generally asymptomatic. And the adenoma are of the two types, in terms of the lipid containing lipid rich and the lipid poor adenomas. Lipid poor adenoma is challenging for us, which is around the 30%. And adenomas are also the hyperfunctioning and the non-functioning. Hyperfunctioning adenoma leading to the Cushing disease or the Cohen syndrome, and the non-functioning adenoma is asymptomatic. And large adenoma may show some cystic component, calcification, and the hemorrhage also. So it is the complicated type of the large adenoma, and usually the size of the adenoma is around 1 to 3 centimeter. But if complicated, its size will be increased. Imaging features of the adenoma on ultrasound. Generally, adenoma size is generally 1 to 3 centimeters usually, and difficult to detect on the ultrasonography. And if detected on the ultrasonography, it appears as a hypoechoic, well-defined, rounded. No vascularity is seen on the colored Doppler images. And on the non-contrast CT scan, it is demarcated by the well-defined rounded or oval lesions homogeneous and relatively low attenuation value less than 10 HU. On enhanced CT scan, CT scan is not always diagnostic, since 15 to 30% adenomas are the lipid poor, which is challenging for us. So contrast enhanced CT scan is the diagnostic, and contrast enhanced CT scan is diagnostic, and it includes the non and the contrast protocol for the contrast enhanced CT scan include the non-contrast CT scan and the portal venous CT scan, which is at the 60 centimeter, and the delayed scan at around the 15 minutes. But and the protocol for the CT protocol for the adrenal lesion is important for the examination. It includes the non-contrast CT scan of only the limited section of the adrenal gland, and in the venous page it should include from the dome of the diaphragm to the iliac crest or the pubic symphysis. But in the delayed 15 minutes phase, it only includes the adrenal gland with the limited section of the adrenal gland. Okay, and if the absolute percentage washout is greater than 60% and the relative percentage washout is greater than 40%, it indicates the adenoma. And another case of the adrenal lesion is I am showing here. This is the T1 non-fat side image, and this is the T1 out phase image, which is shown by the Indian ink appearance of the microscopic fat. And here is the axial section of the T1 non-fat side image is showing there is an isodense lesion in the left adrenal lesion, which is appear as a well-defined oval lesion. And on the T1 out phase images, it is showing the drop of the signals. And what is the diagnosis of that? It is again the case of the adrenal adenoma. So chemical shift imaging, T1 and the T1 in phase and out phase is used to detect the intralesional fat in the microscopic type of the fat. If you want to diagnose the microscopic fat of the lesion, then the T2 fat site is the most appropriate sequence. And the loss of signal in the opposite phase images, it detect the intralesional microscopic fat, and decrease in the signal intensity greater than 20% is considered diagnostic of the adenoma. So the loss of signal intensity quantified using the parameters such as the splenoadrenal axis and the signal intensity index, and the splenoadrenal ASR in the adrenal spleno the ratio is greater than 70% is highly specific for the adenoma, and the signal intensity index greater than 16.5% is the specific for the adenoma also. But the MR sensitivity for the lipid poor adenoma measuring greater than 30 HU is significantly lower. Thus, the contrast enhanced CT scan remains the gold standard, especially in the evaluation of the lipid poor adenoma. So adrenal to spleen ratio is also important. So should be remembered, and do practice to remember this, and just like the absolute percentage was out and the relative percentage was out. And so adrenal to spleen ratio is lesion signal intensity in opposite phase divided by the spleen signal intensity on the opposite phase, and whole divided by the lesion signal intensity in phase, and divided by the spleen signal intensity in the in phase. And the signal intensity index is equal to lesion signal intensity in phase minus lesion signal intensity in opposite phase into 100% divided by lesion signal intensity in phase. So adrenal to spleen ratio less than 0.71 is the diagnostic of the adenoma, and the signal intensity greater than 16.5% also indicates in favor of the adenoma. And some salient typical features of the adrenal adenoma, because it should be also remembered, because if the same type of the questions are in the examination, so this should be remembered as a typical appearance of the adenoma also. Atypical features of the adenoma includes the heterogeneous density, incomplete of washout on the post-contrast imaging, and presence of the macroscopic fat and the calcification. Adrenal adenoma with the calcification representing the 14% of the adrenal adenoma. And adrenal edema with the hemorrhage usually occurs in the patient receiving the anticoagulation therapy. It is also important for the spotter examination that adrenal adenoma is showing the hemorrhage. And the adrenal adenoma with the myelomatous degeneration means the foci of the myelomatous degeneration appear as the areas of the fat adenoma. So it means the mixed up type the appearance seen in the adrenal adenoma with some fatty component and the myeloid tissues. I'm describing this in details because this type of the complicated type of the adrenal adenoma may be asked in the examination. And the adrenal adenoma may also converted into cystic changes. Here is we can see there's a large hypodense lesion with the punctate of the few calcific foci seen in the left adrenal involving the left adrenal gland and also according the paravertebral mass with well-defined margins. It indicates also that it is the benign type of the lesion. But the exact diagnosis should be made only by the imaging, and the final diagnosis will made by the biopsy also. And the atypical large adenoma is greater than the 4 centimeter in the size, mixed lipid rich, and the lip poor adrenal adenoma we can also see. And the mimics of adrenal adenoma is the small adrenocortical carcinomas, adrenal collision tumors, simple cyst, and adrenal metastasis. What is adrenal collision tumor? Adrenal collision tumor is very important, and the question of the viva and the question for the examination is also it is the collision tumor. It means two types of the histological components are seen within the same lesion. When there's some components contain the adenoma type of the features, and some tumor contain also the features of the malignancy or the myelolipoma type of the features. That is the adrenal collision tumor. And adrenal collision tumor is apart from the adrenal glands where it is found. It is also found in the liver as a cholangiohepatocellular carcinoma, and also in the ovary. We are very frequently seen in the liver as a cholangiohepatocellular carcinoma. So it is important. It is adrenal collision tumors. And the fourth spotter is the contrast axial CCT abdomen is showing that there is a punctate area, there is a chunky calcification in the region of the bilateral adrenal gland, and the rest of the liver and the spleen and the rest of the visualized organs appears normal. So the chunky calcification, the coarse type of the calcification, it indicates the benign nature of the disease. And India is a very endemic zone of the tuberculosis. So this is the case of the any chronic gallimomatous disease, likely the tuberculosis. So the bilateral adrenal involvement is also seen with the tuberculosis, histoplasmosis, blastomycosis, Mycobacterium avium metascellari, and the cytomegalovirus. Tuberculosis and the histoplasmosis are the most frequent type of the diseases which are encountered in our day-to-day practice. And the histoplasmosis and the tuberculosis in the acute phase appears as a well-defined heterogeneous type of the lesion involving both the adrenal glands and the few of the necrosis foci also noted within both the adrenal lesion, and there may be some types it is also found with the few calcium. In the acute stage, no calcification is seen, but in the chronic phases, and the calcification may be seen, and this type of the infection leading to the chronic adrenal insufficiency. So patient can be presented with the hypotension and the hypotension, hypovolemic lethargies, weakness. These are the features of the chronic adrenal insufficiency. And the next spotter is this is the arterial phase contrast CCT abdomen, and this is the coronal phase CCT abdomen, with the and the axial contrast CCT abdomen is showing there is a well-defined rounded fat attenuating lesion seen in the suprarenal location, better seen in the coronal view, and it is also seeing the some the heterogeneous content within the with apart from the fatty component. So what is the diagnosis? Diagnosis is obvious. It is the myelolipoma, because myelolipoma is that because the apart from the lipid content, the inhomogeneous isodense slightly the area appears as a myeloid tissue. So it is the case of the myelolipoma. And another case on the ultrasonography images is showing this is the liver, this is the kidney, and this is the hyperechoic area with some hypoechoic area in the central region of the lesion, and the lesion appears well defined, rounded, and abutting the liver and the kidney with the posteriorly in the diaphragm, and this is the IVC. And the on the vascular and the color Doppler, it is not showing any obvious vascularity, so it is indicating on the basis of the imaging it looks like as a benign lesion. So likely the diagnosis of the ultrasound the appearance of myelolipoma. So myelolipoma is the benign tumor, usually unilateral, small, and often detected incidentally. It consists of the mature fat and the hematopoietic cells. Amount of fatty component is variable depending upon the soft tissue mass or almost complete fat. Here in the non-contrast CT images, we can also see there is a fatty component with the inhomogeneous, the hypodense soft tissue within the suprarenal location. And the myelolipoma infrequently contain calcification or shows partial replacement by the hemorrhage or the fibrosis. Larger lesion becomes symptomatic due to the pressure effect, and intralesional hemorrhage or the infarction. A smaller lesion managed conservatively, and the larger lesion greater than 4 centimeters are likely to be surgically removed. It is also important which lesion should be followed up or managed conservatively, or which lesion should be removed surgically. This is important, so please remember it. And on the ultrasonography, the lesion appears as a hyperechogenic. The echogenic are the hyperechoic areas with the central hypodense area, and the hypodense area represents the myeloid tissue, and the hyperechoic area represents the fatty component. Frequently, the lesion has appearance of the mixed type of the hyperechoic and the hypoechoic areas due to the varying amount of the fat and the myeloid elements. And there is no vascularity noted within the lesion. This is the classical picture of the myelolipoma, and should be kept in the mind also. And the CT appearance of the myelolipoma include the just as the benign lesion with the finding rounded mass with the well-defined borders. Densities varies depending upon the portion of the fat and the myeloid components, internal separation, necrosis, hemorrhage, or the calcification. Gross fat is almost always detectable with the fat with the attenuation less than -30, and the slight enhancement after the contrast injection is seen because it is poorly vascularized. And another lesion of the myelolipoma, we can see the non-contrast CT images showing the fatty fat attenuating area with some homogeneous isodense area on non-contrast imaging in the supracellular location, better seen in the coronal view. And this is the axial section contrast imaging showing and no any enhancement. And in the coronal view, we can see there is no obvious enhancement. So this is also the case of the myelolipoma. And another case of the myelolipoma is showing the less fat as compared to the previous shown lesion, and also the some isodense content within the. This indicates the fatty component and the myeloid component varies with the different types and the same entity like the myelolipoma. So this is another case of the myelolipoma. If you have to do the biopsy, then we have to take the posterior approach, like the paravertebral region. Yeah, we can also go through the transhepatic route also. Yeah, we can also put the patient in the decubitus view with the right side down, and we should introduce the needle to this slide to avoid the pleural puncture. And this is another case of the myelolipoma showing the minimal the slight enhancement with the myeloid tissue and the fatty component, and the coronal view it is very beautifully seen. I'm showing the more picture of the myelolipoma because it is most frequently asked spotters in the examination. So you should remember all these appearance types of myelolipoma in one spot. So I am showing the large number of cases of the myelolipoma. And the next spotter is the non-contrast CT scan images is showing there is a well demarcated the fat attending lesion in the suprarenal location with the eccentric foci of the calcification. If eccentric foci of the calcification with the fat attenuation came in the images, then the diagnosis should be the lipoma. Adrenal lipoma are the rare tumor of the mesenchymal origin containing mature fatty tissue and surrounded by a fibrous capsule. On CT, in contrast to myelolipoma, they show no or the minimal soft tissue attenuation and contain focal areas of intralesional calcification due to degenerative changes. Fat containing adrenal lesions is the intracellular, if the intracellular fat is adenoma macroscopic fat, and the intracellular fat adenoma is showing the loss of signal intensity on the chemical shift imaging, and the macroscopic fat containing lesion is showing the loss of signal intensity on the fat separate imaging. This is the important and the confusing fact. So must be remembered that the loss of signal intensity on the chemical shift imaging is indicating of the macroscopic fat which is found in the adenoma, and the for macroscopic fat loss of signal intensity on fat separate seen on the T2 images. Myeloma fat with the heterogeneous myelolipoma fat with the heterogeneous myeloid tissue, and the lipoma contains the fat with the calcification. Myelolipoma contains the fat with the heterogeneous myeloid tissue. Lipoma contains the fat with the calcification. Both are the containing the macroscopic type of the fat, and only the adenoma containing the intracellular fat, which is showing the loss of signal intensity on the chemical shift imaging. And this is the axial contrast enhanced CCT abdomen is showing there is a well defined rounded lesion seen in the left adrenal gland, which is slightly appears lobulated in the appearance, and the margin is the slightly enhancing with thin wand, and it appears as a fluid attenuating area. So the diagnosis is the adrenal cyst. So adrenal cyst is also very important because sometimes the adrenal cyst can mimic as an adrenal adenoma, metastasis, and all this. So you should must be remember these findings and should be carefully while reporting the adrenal cyst versus the adenoma versus the metastasis. On the adrenal cyst appears as a non-enhancing hypoattenuating area with water attenuation less than 20 HU with and thin walls on and the thin walls, and the wall appears thin and it is smooth, and on contrast it appears as a peripheral enhancement. And on MR, cysts are usually hyper intense on T2 weighted imaging. Septation blood products are a soft tissue component, and the calcification may be absorbed in the pseudocyst. So this is the T2 fat set imaging, and this one is the T1 fat set images, and this is the post contrast enhanced T1 post contrast enhancement images, and the T2 fat set images showing that the lesion appears as a T2 bright signal, and the T1 it appears as a hypointense signal intensity, and the T1 post contrast is showing only the peripheral enhancement without the central enhancement area, and no obvious the calcification, soft tissue component, or the separation of the blood product as seen. So the diagnosis is only the adrenal simple cyst. It is important because the smaller adrenal cyst appears as an adenoma, so must be remembered and measured the HU water attenuation. It is less than 20 HU, and the measurement of the HU is to just put the ROI with the 2/3 of the area of the lesion, not more than the lesion, because if you are putting the ROI over the lesion, then it will also detect the perilesional fat, which is the retroperitoneal fat, and it will falsely give the negative value. So ROI measurement is important. So measure it in a correct manner. And another case is this is the non-contrast CT scan. This is the arterial phase CT scan, and this is the portovenous CT scan. In the non-contrast CT scan images, it is showing there is a hyperdense content completely replacing the right adrenal gland. And the arterial phase, no obvious enhancement is seen as compared to the non-contrast images. If any enhancement, the pattern of the enhancement have to comment on that. We should remember from the we should compare from the non-contrast imaging. If there is no enhancement, then it must be there is no enhancement as compared to the non-contrast images. And in the portovenous phase, it is showing only the peripheral subtle enhancement. So the diagnosis is the hyperdense content, large hyperdense content in the right adrenal lesion. So likely the diagnosis is the adrenal hemorrhage. Adrenal hemorrhage is the most important thing, and it will be found in the sepsis, patient on the anticoagulant therapy, trauma, complicated pregnancy leading to the hypercoagulable state, and the stress and the prolonged surgery. So acute hemorrhage can produce a mass effect with a diameter, with a usual diameter of 3 to 4 centimeter, maybe large in the large retroperitoneal hematoma in the case of the trauma, or in case of the uncorrected coagulopathy, with a mixed type of the texture, predominantly the hyperechoic. And ultrasonography, acute hemorrhage appear as a solid homogeneous mass, and the later on the hemorrhage has a tendency to become the liquefied as with the progressing of the time. So it leads to the heterogeneous appearance, and eventually when the later on the mass completely liquefy and appears as a cystic, and the hemorrhage appears initially as a solid homogeneous mass. So on CT, acute hemorrhage is characterized by the high attenuation values in the post traumatic cases associated with the hemorrhagic effusion of the periadrenal fat and the retroperitoneal bleeding. And the chronic hematoma appears as a mass with the hypertonic center with or without calcification, also termed the adrenal pseudocyst. Hematoma usually decreases in size and may spontaneously disappears. And this is a very interesting case. And this would I think each and everyone will be familiar to this case. And this is the non-contrast CT images, and this is the arterial phase CT images, and this is the portovenous CT images, and this is the delayed type of the CT images. And on the non-contrast images, we can see there is a foci of the calcification within the hypodense lesion, which appears to be well demarcated and well defined, rounded without any invasion to the surrounding tissue. Only the upper the segment 6 of the liver, and in the arterial phase, it is showing the centripetal peripheral and centripetal enhancement, and the portal venous phase, it appears to be the increase in the enhancement size, and in the delayed phase, it almost completely filling the lesion. And apart from this, there is another lesion seen in the left adrenal gland, but we are concerning only with the right adrenal lesion. So I'm showing exporters for this right adrenal lesion. The purpose is that, so this is the diagnosis is obvious, and it looks like the hemangioma, because it is showing the progressive filling, arterial phase, venous phase, and the delayed phase. So it is the case of the adrenal hemangioma. And the adrenal hemangioma is often large at the presentation, and the female has a more predominance of the appearance. And it's of the 4 types. Cavernous hemangioma is the most common type, venous hemangioma, capillary type of the hemangioma, and the mixed type of the hemangioma. And on the CT, hemangioma appears as a well circumscribed, homogeneous, with low density lesion with speckled of the calcification phleboliths are characteristic of the hemangioma. And in the contrast enhanced CT, it appears as a peripheral discontinuous nodular enhancement, which is classical for the hemangioma. But hemangioma can show the different type of the enhancement also, not the nodular. It shows the peripheral enhancement, certain bloods in the arterial phase, and which was the progressively filling all the lesion. So this is the case of the adrenal hemangioma. And on the MRI, MRI hemangioma is showing the hypo-intense signal intensity on the T2 and high signal intensity on the T2 phase, and showing the similar pattern of the enhancement as of CT. And this is a very interesting case number the 11, and this is a non-contrast CT scan, and this is the CCT axial phase images, and on the non-contrast imagery we can see there is a well-defined rounded hypodense lesion in the left adrenal region, left adrenal region or left adrenal glands, and another we can see there is a hypodense lesion seen in the left adrenal gland, and in spite of the lesion we can see there is a air foci. This is the clue of the lesion. And on the coronal view we can see the lesion is aborting the adrenal gland, and this is the stomach, and this is the hypo enhancing lesion is here. And in the again in the coronal view, in the most posterior section, we can see the adrenal is separately visualized, and this is the lesion, and lesion is showing the air foci. So in the coronal section, in the axial section, it seems like a adrenal lesion, but in the coronal section, it looks like a extra adrenal lesion. So before making so our aim is to show this case to before making the diagnosis on the axial view, we should know the coronal view also, so that we can make the appropriate diagnosis, because the lesion appears in the axial view, it appears as an adrenal lesion, but in the coronal view it appears separate from the adrenal. So this is the pseudo lesion, and pseudo lesion comes from the stomach. So this is the posterior stomach wall diverticulum. So answer is the posterior gastric diverticulum mimicking the adrenal lesion, means the pseudo lesion. Pseudo lesion is what? Pseudo lesion is non-adrenal pathologic conditions have been reported to mimic the appearance of an adrenal mass of the city. This is the important features. And the differential diagnosis of the pseudo lesions include the splenomegaly, varices, exophatic hepatic mass, dilated colon, splenic lobulation or pole renal mass, splenic arterial aneurysm, and the gastric diverticulum. But splenic artery aneurysm on the non-contrast scan, it can simulate as a pseudo lesion, because in the arterial phase it will be enhancing as a aorta, and it will follow the broad full images. Okay, that will be the differential diagnosis of all. So we should remember all these things, and now the next exporter is the axial CCT images showing there is a homogeneous mass in the left adrenal gland, and also the right adrenal gland without any necrosis, calcification, and it is almost the homogeneous, and also involving the extra adrenal fat tissue. So this is the classical appearance of the adrenal lymphoma. This is the case of the adrenal lymphoma. And the another exporter is the adrenal gland appears bulky with maintaining of its shape, inverted Y shaped, and also the maintaining both the adrenal glands are involved. And the coronal section we can see the adrenal gland, and the left adrenal gland also maintaining its the normal pyramidal shape, and the only the thickening of this. So this was the case of the adrenal hyperplasia. In the adrenal hyperplasia, adrenal gland appears the bulky with maintaining its normal shape. This is the important features. So this is the case of the adrenal hyperplasia, and the cause of the adrenal hyperplasia should be remembered, all these things. And this is another important case. We can see there is a large lobulated heterogeneously enhancing mass in the CCT abdomen showing on both the adrenal region without the separate visualization of the adrenal gland. It is also avoiding the tail of the pancreas, and lesion appears the lobulated with some soft tissue component. And in the coronal view, it is beautifully seen the large bilateral adrenal mass lesion with some heterogeneous component within it, and it is also showing there is a thrombus in the IBC. This is the thrombus part, and this is the portal venous part. Portal venous part is not clearly visualized, but it was and this is the IBC portion, and the IBC is the thrombosed. So it was the and we can see this lesion, and we can see in the coronal view in the lung there is a large mass in the lung region, which appears to be the necrotic with the peripheral enhancement. So before making the diagnosis of the bilateral adrenal lesion, we should search for the another lesions in the another organs. Is there any possibility with the other lesions seen in the other organ? If yes, then your diagnosis will be very easy. If no, then we have to work more. And if the lesion is if the other organs show the lesion, just like as a bilateral adrenal lesion with the lung apical lung lesion, then the diagnosis is very clear. So this is the case of the adrenal metastasis due to the lung carcinoma. Another case of the same pattern. It's a large. This is the coronal view CCT imaging showing there's a large mass with the fat component and the heterogeneous soft tissue minimally enhancing component and producing a mass effect on the kidney. Mass effect of the kidney is shown by the upper pole is blunted by the due to the mass effect of the lesion. So this is the case of the myelolipoma again. And this is the next spotter is the axial contrast CCT abdomen and the coronal view contrast CCT abdomen, and there is a mildly enhancing soft tissue component seen in the right suprarenal region, apart from the fatty liver composition of the liver, and we can see in the coronal view the lesion appears slightly infiltrating into the adjacent liver parenchyma. So the diagnosis is because the patient was the known case of the ovarian carcinoma. So the diagnosis was made as the unilateral metastasis due to the ovary. Metastasis at the primary adrenal carcinoma both can invade the adjacent organs. So the another spotter is the frontal epiradiograph of a child, and another side of the image is the coronal CCT image of the abdomen. We can see there is a sutural diastasis, and there is a multiple tiny punctate radiolucent lesions seen in the skull, and the sutural diastasis is the classical picture and the classical diagnosis of the any infant or the pediatric children is the neuroblastoma. We can see there is a heterogeneously enhancing lesion seen in the suprarenal location with the coarse calcification, chunky calcification, the arc-like of the calcification seen in the lesion. So it is indicative of the neuroblastoma. So it was a case of the neuroblastoma with metastasis. Another spotter is that there is a heterogeneously enhancing lesion seen in the left suprarenal location, which is showing the soft tissue component and the chunks of the calcification and the inhomogeneous soft tissue. So the diagnosis is obvious, and also avoiding the renal parenchyma, and the size of the lesion is larger appearance of the size. It was not measured, so likely the diagnosis in the spotter is the adrenal cortical carcinoma. But sometimes the diagnosis becomes difficult, so we have to do the biopsy also. And this is the spotter of the axial contrast CCT abdomen showing there is a normal enhancement of the right adrenal gland, and the left adrenal gland appears non-enhancing, and also appears the bulky. So this is the case of the adrenal infarction. So adrenal infarction should also be diagnosed with the certainty, and also we should in the MRI, in the diffusion DWI sequences, we can see the diffusion restriction of the infected the tissue, and left adrenal gland infarction. And this is the important and the intervention radiology. So I'm asking one question from the intervention, and this is the important features, and this is the important for the adrenal. And name the procedure. This is the catheter placed in the IVC, and this is the primary. This is the tip of the catheter going into the renal vein. This is the course of the IVC, and this is the course of the renal vein. And the renal vein is, and the tip is renal vein is going to the left adrenal vein, because left adrenal vein is opening into the left renal vein, and right adrenal vein is directly open into the posterior wall of the IVC. So it is a case of the the procedure of the left adrenal venous sampling, because left adrenal vein is the confluence making the confluence with the inferior sphenic vein, and the adrenal vein combines with open into the left renal vein. So this is the case of the left adrenal venous sampling. So it is important aspects because we are dealing with the adrenal pathology. So should know about the adrenal venous sampling also. Adrenal venous sampling, getting the approach from the common femoral vein after puncturing, then introducing the catheter, the guide wires in the common femoral vein through the IBC, and this is the area of the IBC, and here is the adrenal left renal vein course, and here is the left adrenal vein course. So this is the classical picture of the left adrenal venous sampling. So what is the indication of the adrenal venous sampling? Commonly performed in the primary aldosteronism, indicated to identify aldosterone secreting adenomas. Suppose if you are diagnosed the one side is the adenoma and another side appears the normal, then the endocrinologist wants to know whether it is the functioning adenoma or the non-functioning adenoma. Then we should do the adrenal venous sampling from the both sides, right side and the left side both, to differentiate adenoma from the bilateral adrenal hyperplasia. It is also indicated, the adrenal venous sampling, and to identify biochemically proven pheochromocytoma when there is not visible any lesion sitting on the other imaging modalities. So it is also indicated to do adrenal venous sampling, and rarely indicated nowadays for the adrenal Cushing disease or the syndrome of the androgen axis. Frequently referred for the diagnosis if the biochemical findings are the indicative of the functioning adenoma, but the CT and the MR pictures appears normal, then it will be referred for the adrenal venous sampling. This is the important also. So this is our exporter cases, and now we are showing the long cases. Long cases. This is the 35-year-old female complaining of the chest pain and the abdominal pain. So we did the first we did the CCT abdomen, chest and the abdomen, and but I am showing the first the image of the abdominal images, and in the abdominal images we can see there is a heterogeneously enhancing well-defined rounded lesion seen in the left adrenal gland, and another heterogeneously enhancing lesion in the right adrenal gland, and there is a small few hypodense lesion, likely the lymph nodes seen in the left adrenal region. And apart from that, we should also see the other organs. Is it normal or the abnormal? We can see there is a hypodense hyponon-enhancing areas seen in the segment 6 of the liver. So it is obvious it is the case of the metastasis. Okay, then we can see in the chest radiograph, we can see there's a large mass seen in the necrotic mass seen in the lung involving the hilum, and this was the case of the and we can see in the coronal view also there's a large located mass in the lung, and also there is a liver lesion and the bilateral adrenal lesion. So it was the case of the lung carcinoma with the liver and the adrenal metastasis. And this is the interesting cases of the 69-year-old female patient complaining of the pain in the right hypochondrium. And I found it recently, and the patient was misdiagnosed from the outside as a liver lesion. So the patient came for us for the contrast CT abdomen, but retrospectively we did also the ultrasound of the abdomen. So we are showing to you that for the first ultrasound, the images of the done by our side. So this is the ultrasound images with the color Doppler images, and we can see the lesion. This is the kidney, and this is the suprarenal portion of the region, and the lesion is found in the suprarenal location, and the liver is very clearly seen. And this is the diaphragmatic shadow. So this is the lesion in the segment 6 of the lesion in the suprarenal location and abutting the segment 6 of the liver. And we can see the lesion is away from the liver, and here is the IVCs. We can see very clearly, and the lesion is showing the cystic necrosis area, and on the color Doppler it is showing the peripheral enhancement and also the few foci of the central enhancement also with the necrosis component. And we can see in the zoom image the liver appears normal. Here is the kidney, here is the lesion, here is the gallbladder showing the calculus, and this is the liver. So this is the suprarenal location. So we did the contrast CCT abdomen, including the non-contrast. Also, in the non-contrast images, we can see there is no calcification in the lesion. We can see here the lesion is here, but there is a lesion is here, but with no calcification is seen. So on the arterial phases, we can see the lesion is brilliantly enhancing with the peripheral enhancement, just like the aorta enhancement. We can see here with the central non-necrosis, inhomogeneous central necrosis areas, which is showing inhomogeneous enhancement, but the whatever the component of the lesion is enhancing, which is showing the intense arterial peripheral phase enhancement. So in the delay, so in the coronal phase, we can see the lesion is in the suprarenal location. This is the kidney, this is the lesion, and this is the liver. But in the lesion, the boundary of the lesion appears the well-defined, rounded, without any organ invasion. So on the venous and the delayed phase images, it is showing the washout but retaining the contrast. So in the arterial phase images, its HU is 291, and the delayed phase images, it is showing the 140 HU. It was done to rule out the hepatic lesion, because the patient referred for the rule out the hepatic lesion. That's why we did the only the protocol according to the hepatic lesion, not according to the adrenal protocol. Adrenal protocol is the different. Adrenal protocol is a non-contrast images of the limited abdominal section, and there is a photovenous phase of the 60 seconds, and there is the delayed 15 minutes delayed. Okay, and so the diagnosis is obvious, and the first differential diagnosis of this lesion is the pheochromocytoma, and second differential lipid poor adenoma, and the adrenal metastasis is DD, and the adrenal cortical, but the diagnosis is obvious in by the imaging features. So it was the final diagnosis made on the basis of that is the pheochromocytoma. Pheochromocytoma is showing the great arterial phase enhancement as compared to the lipid poor adenoma, and the hypervascular metastasis is also showing some enhancement, but there is evidence of the cancers or the hypervascular lesions, other part of the organs. But here is no only this limited only the limited lesion is seen in the right adrenal gland. So diagnosis is the pheochromocytoma. An ultrasound appearance, the pheochromocytoma can be seen as a solid to the mixed cystic and the solid to the cystic lesion. And then the CT lesion appears the heterogeneous masses with areas of the necrosis and the cystic changes. Density always greater than 10 HU, typically enhanced avidly. 1/3 of the cases may wash out similar to adenoma, but they tend to have a greater enhancement in the arterial portal venous contrast phases. However, overlap with some hyper-enhancing adenoma. Okay, but tend to enhance more on the portal venous phase than the arterial phase, and 110 to 120 HU of the enhancement in the arterial phase suggests the pheochromocytoma, but is not a specific. Hypervascular metastasis could be considered in the appropriate setting when there is a case of the hypervascular cancers, and 10% cases demonstrate the areas of the calcification also. And on MRI, the pheochromocytoma appears tumor as a hypointense, and if necrotic at the hemorrhage, then the signal will be more heterogeneous. And in T2 appears as a hyperintense, making the light bulb sign, and 1/3 of the cases don't have T2 marked hyperintensities. And in phase and the out phase, no signal loss. On out phase imaging, pheochromocytoma rarely contains a significant amount of the intracellular fluid. And the T1 contrast heterogeneous enhancement is prolonged, persisting for as long as 15 minutes. So this was the case of the pheochromocytoma, and the interventional procedure relating to the adrenal gland includes the adrenal venous sampling and the percutaneous biopsy. These are the two most frequently encountered the venous interventional procedures. Percutaneous biopsy for the larger lesion posterior approach is good. For a smaller lesion, we have to do the decubitus position to provide the pleura function, and occasionally transhepatic approach can also be done depending upon the operator compatibility, and it is also safe. The transhepatic approach, there is a chance of the bleeding as same as the interventional procedures. Okay, and the thank you. Now I'm going to stop the lecture, and hope you will be like it. Thank you all.
Thank you so much, Dr. Chandan, for showing such a comprehensive collection of your adrenal cases, and you have covered almost all the cases that are shown in the exam, and yes, given all the important tips and points for the resident. Thank you so much.
Okay, thank you, ma'am.
So if we have any queries for this session or the previous one, you can post your questions in the chat box and the speakers would be happy to answer. Meanwhile, Sarita ji, you can show the flyers for tomorrow's class, and if you have for the ensuing Sunday class as well, we can share those with the residents. And if there are any queries, we can wait for them to come. Right, so this is the flyer for tomorrow's class on MSK imaging, and we have talks, case-based discussions rather, on elbow imaging and hip imaging by established speakers. So do attend. And okay, this Sunday we have again MSK imaging by the ICRI Vidyapeeth, and we have a spotter session followed by case-based review